Welcome. If you're listening to this, you are likely a medical student or maybe a public health trainee. You might be a junior doctor or even a practicing clinician. You're someone who has, dedicated years of your life to mastering the really intricate microscopic mechanics of human health.
Right, the biochemical pathways, the surgical plane.
Exactly, the pharmacology, all of that.
Right.
But today, we're asking you to step back. We're taking you on a conceptual journey that goes far beyond the anatomy lab or a busy ward. I want you to imagine healthcare, not as a simple, straightforward transaction where a patient presents a symptom and you provide a cure. Instead, I want you to visualize healthcare as this massive, ancient, walled citadel.
I've always thought that's a remarkably powerful image. And honestly, it perfectly captures the reality of what we in public health call the architecture of access.
Yeah, just picture this citadel in your mind.
Yeah.
Inside its towering walls, you have everything. There are life-saving treatments, brilliantly trained specialists, sterile operating theaters, cutting-edge preventative care. Now, some people in our society are simply born inside those walls. They never even have to think about how to get in. If they get sick, the clinic is literally down the hall.
But then you have people born outside.
Right. Some of them are handed a golden key at birth. Maybe that's comprehensive, premium private insurance, or just generational wealth. But for millions of others, just getting to the edge of the citadel requires crossing a massive physical moat. Maybe they live in a deeply rural area, hours away from the nearest secondary care facility.
And the real tragedy of system design is that even if they manage to cross that geographic moat, their journey is rarely over.
Oh, absolutely. They finally get inside the walls, only to find a labyrinth of locked doors. These are the organizational barriers we see every single day, the month-long wait times for a rheumatologist, the incredibly complex referral systems that require health literacy most people just don't possess, or, frankly, profound systemic discrimination right at the front desk.
Yeah.
And then, the most heartbreaking scenario, someone finally unlocks a door, completely exhausted, only to step into an empty room. They receive care, but it's of such poor quality or so wildly inappropriate to their actual clinical needs that it offers absolutely no benefit.
Which really brings us directly to the mission of today's deep dive.
Yeah.
We are not here to just summarize a dry list of public health facts for an exam.
Mm-hmm.
We're here to build a robust analytical framework to help you understand exactly how and why healthcare systems are designed the way they are.
Right.
We're going to explore access as a deeply multidimensional concept. Because as clinicians, we have to move our thinking from the simple logistical availability of a clinic all the way through to effective coverage and actual measurable population health outcomes.
And before we get too deep into the weeds, a quick reminder. This deep dive is designed as a direct companion to Chapter 2.0, along with some really vital foundational concepts from Chapter 11.4 of the Oxford textbook of Global Public Health. We highly encourage you to read those chapters alongside this audio.
Think of us as your guides, helping you actively navigate the material, pull out the frameworks, and anchor them to your memory so they actually stick when you're out there practicing.
So the central question we'll be unpacking today might actually sound almost absurd to a practicing clinician at first glance. And the question is this: does healthcare actually improve population health?
I mean, my immediate clinical instinct would be to say, well, of course it does. I saved a life on Tuesday.
Exactly. It sounds like a trick question.
It does sound like a trick, and we'll get into why it isn't later on. But historically, this was a subject of fierce, data-driven debate. We're going to deconstruct how access, meaning who gets what when and how, is the true engine of population health, far more than the invention of any single drug.
Okay, let's start at the very bedrock. Before we can even talk about who gets the key to the citadel, we have to ask a foundational question. What exactly is healthcare? Because as clinicians, we're trained to think of healthcare purely as curing a disease. You have a bacterial pneumonia, I give you a beta-lactam antibiotic. You have a displaced fracture, I reduce it and cast it.
But public health requires a much wider lens. It's so much broader than that. Healthcare is about relieving suffering, even when a cure isn't possible. It's about providing prognostic information so a terrified family can actually plan for their future.
Yeah.
Ultimately, access to healthcare dictates a person's fundamental life opportunities. It dictates how their life begins, how it is lived, and when and how it ends.
Precisely. And because it so heavily dictates life opportunities, societies are forced to make a pretty profound choice about how to classify healthcare economically. Is health a private good? Is it a merit good? Or is it a public good? Let's unpack these because they completely change how a country builds its hospitals.
Let's start with a private good. If a society treats health as a pure private good, it means healthcare is bought and sold on the open market, exactly like a luxury car or a flat-screen television. If you have the money, you buy the surgery. If you don't, you don't.
But economists generally agree that free markets inherently fail when it comes to healthcare, right? I mean, markets work pretty well for groceries and electronics. Why not healthcare?
Because healthcare violates almost all the prerequisites of a perfectly competitive market. First off, the risk of illness is utterly unpredictable. You don't plan to get hit by a bus. Second, the costs can be astronomically high, far beyond normal household savings. And most importantly, there is a massive information asymmetry.
The consumer, meaning the patient.
Exactly. The patient rarely has the medical knowledge to make a truly informed choice, especially in an emergency.
Right, you can't really pull out your smartphone and shop around for the most cost-effective coronary artery bypass graft while you're clutching your chest, having an acute myocardial infarction. The market logic just collapses in the emergency department.
It absolutely does. Which is why many societies and the prevailing public health consensus view healthcare as a merit good. A merit good is something that a society believes everyone should have access to, regardless of their individual ability to pay. And society believes this because the benefits of treating an individual extend far beyond that individual.
A healthy worker contributes to the economy.
Yes, a healthy parent raises stable children.
And then we have aspects of healthcare that aren't just merit goods, they are pure public goods. This is the stuff that protects the whole citadel. Think of infectious disease control or sanitation. If I treat a patient for active pulmonary tuberculosis, yes, I am curing that individual. But the massive positive externality is that I am protecting the entire community from an outbreak. You can't restrict the benefit of infectious disease control only to the people who paid for it.
Which brings us to the massive ideological tug-of-war that shapes every single health system on Earth. And we're going to look at this purely objectively as observers of system design. Broadly speaking, you have two major philosophical camps competing to design the citadel.
Let's look at the libertarian view first. We see heavy elements of this in the United States system, for instance. In this view, healthcare is primarily an individual responsibility. Fairness, in this specific ideology, means that everyone has an equal opportunity to compete for resources in the market. It does not mean a guaranteed distribution of those resources.
And on the other end of the spectrum, you have the egalitarian view. This approach, which was explicitly endorsed by the United Nations General Assembly in their 2012 resolution on universal health coverage, views healthcare as a fundamental societal obligation. It argues that a just society must actively pool risks. The healthy must underwrite the sick, and the wealthy must underwrite the poor.
And if we dig a little deeper into the ethics here, this ideological split mirrors a very old philosophical divide. We're talking about the utilitarian approach versus the human rights or Rawlsian approach. As clinicians, we actually use both, sometimes without even realizing it.
Let's unpack the utilitarian approach. This is the philosophy of the greatest good for the greatest number. It focuses relentlessly on maximizing efficiency. If a health minister has a limited budget of $10 million, a utilitarian wants to buy the absolute most health possible with that money. They measure this in quality-adjusted life years, or QALYs.
Oh, right.
They want to maximize aggregate population health, even if it means some individuals with rare, incredibly expensive conditions might not get funded.
And honestly, when you're managing a national budget, that cold mathematical logic makes a lot of sense. But as a doctor standing at the bedside, my instinct is to fight for the patient right in front of me, regardless of the cost effectiveness. That clinical instinct aligns much more closely with the human rights approach.
Exactly. The human rights approach, often linked to the philosopher John Rawls, argues for justice as fairness. Rawls proposed a famous thought experiment called the veil of ignorance. Imagine you are designing a society, but you don't know who you will be in that society. You don't know if you'll be born rich or poor, healthy, or with a severe congenital disability.
Well, if I'm behind that veil, I'm definitely designing a system with a massive safety net because I'd be terrified of being born vulnerable.
Precisely. From a human rights perspective, the focus is on social justice and fair equality of opportunity. It argues for a right to health for every individual. A rights-based approach says an individual is entitled to care simply because they are human, even if treating that specific marginalized person is absolutely not the most cost-effective way to maximize the aggregate health of the population.
So we have these competing values: efficiency versus equity, utilitarian math versus human rights. Because these values constantly clash, we need a standardized way to evaluate if a health system is actually working. We can't just say, oh, it feels right. We need metrics.
Mhm.
And in public health, the gold standard framework for this is Maxwell's 6 dimensions of quality.
I like to think of Maxwell's framework as the ultimate report card for any health system. Whether you are running a tiny rural clinic or a massive national health service, you have to grade yourself on these 6 dimensions: effectiveness, efficiency, equity, access, appropriateness, and responsiveness.
Let's quickly run through those with a clinical lens. Effectiveness, are the treatments we're giving actually working and improving survival? Efficiency, are we wasting money or resources to get that outcome? Equity, is the system fair? Or are the rich getting better care for the exact same disease? Access, can people physically and financially get to the care?
And then appropriateness.
Right. Are we doing a 5-vessel bypass on a 98-year-old with end-stage dementia? Or are we providing care relevant to their actual needs? And finally, responsiveness, is the system socially acceptable? Does it treat the patient with dignity and respect their autonomy?
Keep those 6 dimensions in your mind because they form the scaffolding for everything we're going to discuss. And the most complex of those dimensions, the one that really determines if the Citadel works, is access.
I'm really glad we're slowing down here because the word access gets thrown around constantly in hospital corridors and political debates. People use it as a synonym for having a clinic nearby. But access is not a single switch that gets flipped on or off. It is a multidimensional chain of events. If any link in the chain breaks, access is denied.
Let's walk through that chain. The first dimension is simple availability. Does the service actually exist?
Right. Let's say we're looking at a remote town. Is there a hospital building with an MRI machine in the town? Yes, great, we have availability, but having a hospital doesn't mean anything if you cannot afford to walk through the doors or if the bus doesn't run on weekends. That is dimension 2, utilization and affordability.
Exactly. You have to overcome the geographic and financial moats.
Yeah.
But let us say you can afford it. You have insurance. You walk through the doors. That brings us to dimension 3, relevance to need or quality. Walking through the butters does not guarantee you receive the correct, evidence-based treatment for your specific condition. You might get a doctor who is burned out or a facility that lacks the proper reagents for your blood test.
And even if you miraculously navigate all of that, the building is there, you can afford it, the doctor gives you the absolute correct guideline-directed treatment, that still doesn't mean you survive. That is the final dimension, outcomes. True access only exists when the entire chain is complete, from the physical building all the way to a tangible improvement in the patient's health.
And this is where modern public health literature has fundamentally redefined how we view access. It's not just about logistics and supply chains, it's deeply sociological. A brilliant concept that completely shifts this paradigm was introduced by the researcher Mary Dixon Woods. It's the concept of candidacy.
I find candidacy absolutely fascinating because it forces us as clinicians to look at our own blind spots. Can you break that down for us? What makes someone a candidate for healthcare?
Candidacy refers to how individuals perceive their own eligibility for healthcare versus how the healthcare providers and the system view them. Dixon Woods described access not as a static thing, but as a dynamic, continuous negotiation.
Okay, give me an example. How does this play out in the real world?
Let's take a marginalized person, perhaps an undocumented immigrant or someone experiencing severe poverty. Do they feel they have the right to show up at a pristine, high-tech, marble-floored clinic and ask for help? Do they see themselves as a legitimate candidate for that care? Often they don't. They self-censor. They stay home because they don't feel they belong inside the Citadel. That is a failure of access before they even leave their house.
And the flip side is just as important. Let's say they gather the courage to go. They walk into the emergency department. When they approach the front desk, does the triage nurse or the receptionist validate them as a legitimate candidate? Or are they stereotyped, judged, or dismissed because of their appearance, their accent, or their inability to articulate their symptoms in perfect medical terminology?
Exactly. Candidacy involves stages: identification of need, navigating the system, a permeability of the services, and the final adjudication by the professional. If a patient is constantly dismissed or made to feel like a burden, they lose their candidacy. Access is deeply psychological.
And that ties perfectly into another vital concept from the literature, Mooney's concept of empowerment. Mooney argued that you can't talk about access without addressing the massive power imbalance that exists in medicine. Think about it. You have a highly educated, authoritative medical provider in a white coat, wielding specialized knowledge, sitting across from a vulnerable, sick, anxious, and perhaps uninsured patient.
Providing a clinic address isn't enough. True access means empowering the patient to navigate the system, to ask questions without fear of being labeled difficult, and to have actual agency in their treatment plan.
So if access is this complex chain of candidacy and empowerment, how do we ensure it's fair? This leads us directly into defining equity. Now, I know we hear equality and equity used interchangeably all the time, especially in political speeches, but in public health, they're entirely different, almost opposing frameworks.
They are. Equality means giving everyone the exact same thing, regardless of their starting point. Equity means giving everyone exactly what they need to reach the same optimal health outcome.
Let's split this into the two types we evaluate: horizontal equity and vertical equity. Horizontal equity is the easiest for most people to grasp. It means equal access for equal need.
Right. If a wealthy corporate CEO and an impoverished factory worker both present to the emergency department with a compound fracture of the tibia, they should both get the exact same level of orthopedic surgery, the same quality of cast, and the same access to physical therapy. Their income shouldn't dictate their clinical pathway.
And we measure this in public health using things called concentration indices. They are mathematically similar to the Gini coefficients used by economists to measure wealth inequality. We use these indices to see if healthcare utilization is fairly distributed across income brackets for a given disease.
But horizontal equity is the easy part. Vertical equity is where the true challenge lies, and where systems often fail completely. Vertical equity demands unequal treatment for unequal need.
Hold on. Unequal treatment. If you pitch unequal treatment to a politician, they're going to run for the hills. That sounds highly controversial.
It does sound controversial in a soundbite, but clinically and ethically, it's essential. Vertical equity asks us, how do we fairly distribute resources when the baseline health needs of different populations are vastly, catastrophically different? The textbook uses a profound and sobering example here: the indigenous populations in Australia. Their life expectancy at birth is roughly 17 years shorter than the general non-indigenous Australian population.
Stop and think about that for a second. 17 years. We're not talking about a statistical rounding error. That's almost 2 decades of human life. That is missing seeing your children graduate, missing seeing your grandchildren born. It's an entire generation erased early.
It is a staggering health disparity. So vertical equity asks, what is a fair distribution of national health resources in this scenario? If the government provides the exact same baseline funding per capita to an indigenous community as it provides to a wealthy, healthy suburb of Sydney, that is equality. But it's absolutely not equity.
Because the starting lines are miles apart.
Precisely. Vertical equity might demand vastly disproportionate funding. It might require entirely redesigned, culturally targeted, indigenous-led primary care services just to begin closing that 17-year survival gap. You have to spend more on the populations that are sicker to achieve an equitable outcome.
Okay, we've laid the philosophical and ethical groundwork. Now we need to ask the hard questions about execution. Are we actually doing things right? This is where we look at the efficiency-oriented approach. And honestly, this is the part of the deep dive that gets really uncomfortable for those of us in the medical profession.
You're referring to the historical critiques of medicine.
Yes. Let's talk about the bombshells dropped by thinkers like Ivan Illich and Thomas McKeown in the 1970s. Because as doctors, we are trained to believe that we are the heroes of the public health story. We think the invention of antibiotics and vaccines is the sole reason people don't die at 40 anymore.
That is the narrative. For a long time, the medical establishment happily patted itself on the back for the massive leaps in human life expectancy over the 19th and 20th centuries. But Thomas McKeown analyzed historical mortality trends in England and Wales, and he pointed out a deeply humbling, data-driven fact.
He looked at the historical data and basically said, wait a minute, medicine didn't cure us. Plumbers, farmers, and architects did.
That is the essence of the McKeown thesis. He demonstrated that mortality from massive killers, infectious diseases like tuberculosis, digestive diseases like cholera, and respiratory illnesses plummeted decades and sometimes centuries before the invention of modern medical interventions like antibiotics or targeted vaccines.
So if it wasn't the doctors, what saved everyone?
The true heroes of historical population health were environmental and nutritional. It was the introduction of clean water and indoor plumbing that stopped waterborne diseases. It was better housing regulations that reduced overcrowding and airborne transmission. And fundamentally, it was improved agricultural output and nutrition, which strengthened human immune systems to fight off infections naturally.
As a clinician, my instinct is to immediately defend my profession. Are you telling me that the invention of penicillin is statistically insignificant compared to a modern sewer system?
Not insignificant, but McKean argued that clinical medicine's contribution to the overall decline in mortality was incredibly minor compared to social and environmental improvements. And Ivan Illich took it even further in his book Medical Nemesis. Illich argued that modern medicine was not only largely ineffective at prolonging life, but was actually causing immense harm through iatrogenic disease.
Iatrogenic harm, meaning illness or death caused directly by medical examination or treatment. It's a bitter pill to swallow, but these critiques set the stage for a massive reckoning in medicine. It birthed the modern era of evidence-based medicine. We realized we couldn't just assume our interventions were working. We had to meticulously prove it because, quite frankly, we were hurting a lot of people.
Yes, and this brings us to Archie Cochrane, a true pioneer in epidemiology. He heavily critiqued the medical establishment for its lack of rigor. He pointed out that countless clinical decisions were being made based on historical tradition, anecdotal experience, or senior doctors' opinions rather than rigorous, scientifically validated evidence.
And when you don't have evidence-based protocols, you get massive, inexplicable variations in care. The sources provide some wild, almost unbelievable examples of this variation. Let's look at cesarean sections in Brazil. At one point, surveys showed the C-section rate in private Brazilian clinics was an astonishing 72%. But in public hospitals in the same country, it was 31%.
Now, a clinician might try to argue that private patients had higher risk pregnancies, but the data just didn't support that. Furthermore, surveys showed that 70 to 80% of pregnant women in both the private and public settings actually wanted a normal vaginal delivery.
So what was driving the 72% surgical rate?
The variation was driven almost entirely by the system's incentives. It was about the doctor's scheduling convenience, the financial remuneration structures in the private sector, and defensive medicine, not medical need or patient preference.
And we see the systemic failure in infectious disease management, too. The textbook highlights data from Pakistan, revealing an average of 13.6 injections per person per year for acute, everyday symptoms. But the terrifying part is that only 53% of those injections were given with newly opened, sterile needles.
Or look at the UK data, where family practices were found to be prescribing antibiotics for 36% of common colds. Common colds are viral. Antibiotics do absolutely nothing for a virus except contribute to global antimicrobial resistance. These aren't just minor inefficiencies. These are profound system failures that cause direct patient harm.
Which brings us back to Illich's point about iatrogenic harm. We have to talk about the famous Harvard medical practice study. This was a massive wake-up call. They reviewed over 30,000 hospital admissions in New York State. They weren't looking for bad doctors. They were looking for system errors. They found that 3.7% of all hospital admissions resulted in an adverse event caused by medical management, not the underlying disease.
And when you project those percentages across the entire United States healthcare system, the estimates were horrifying. It was projected that up to 88,000 deaths annually in the U.S. were caused directly by medical errors. That made iatrogenic harm one of the leading causes of death in the country.
So how do we solve this? How do we build a citadel that actually protects people instead of accidentally harming them? The answer, according to modern public health, lies in health technology assessment, or HTA, and the relentless application of randomized controlled trials, or RCTs.
We have to explicitly measure both the clinical effectiveness and the cost effectiveness of everything we do. And to really understand how to evaluate efficiency and safety in public health, we need to do a deep dive into screening. This integrates directly with the concepts from Chapter 11.4 of the textbook.
I'm really glad we're focusing on screening because it requires a complete clinical mindset shift. As a doctor in a clinic, a patient comes to me because they feel sick. They are asking for my help. But screening is fundamentally different. Screening targets healthy populations. You are actively inviting thousands of people who feel perfectly fine to come in and take a medical test.
And because you are intervening on healthy people, the ethical bar you must clear is incredibly high. You must definitively prove that your screening program will do more good than harm. You cannot just screen for everything.
Right. Just because we have a test for a disease doesn't mean we should use it on everyone. This is why we rely on the Wilson-Youngner criteria from 1968, which remains the gold standard framework. Before you launch any screening program, you have to prove several things. The condition must be an important health problem. The natural history of the disease must be well understood. There has to be a recognizable early latent stage. The test must be safe and acceptable to the public.
And perhaps most importantly, there must be an effective, agreed-upon treatment available for the disease you're looking for. It is considered deeply unethical to launch a population screening program for a devastating disease if you have absolutely no way to help the patient once you find it. You're just inflicting psychological terror.
Let's build the mathematical framework behind screening, because I know from my own exams that this is where medical students often get tripped up. As clinicians, we tend to fixate on sensitivity. Sensitivity is the ability of the test to correctly identify those who actually have the disease. We are terrified of missing a sick patient and sending them home.
But in population screening, specificity, which is the ability of the test to correctly identify those without the disease, is arguably just as important, if not more so.
Let's slow down and break down exactly why specificity is king in public health. It's all about understanding the positive predictive value, or PPV. The PPV is the only number the patient actually cares about. It asks, "Doc, my test came back positive. What is the actual statistical probability that I truly have the disease?"
And here is the counterintuitive mathematical reality that traps so many clinicians. Positive predictive value is heavily dependent on the prevalence of the disease in the general population. There is a direct mathematical relationship. Even if you have a magnificent, incredibly expensive diagnostic test with 95% sensitivity and 95% specificity, if the disease is very rare in the population, say a prevalence of just 0.1%, your positive predictive value is going to absolutely collapse.
Okay, let me grab a mental napkin and draw this out for you, the listener, because this math is vital. Imagine a village of 10,000 people who all feel completely healthy. Now, we know a silent disease is in this village, and its prevalence is 0.1%. So 0.1% of 10,000 means exactly 10 people in this village actually have the disease. The other 9,990 people are totally healthy.
Correct. Now, we roll out our brilliant new screening test. It has 95% sensitivity.
Okay, so we test the 10 sick people. 95% sensitivity means we correctly catch 9.5 out of 10. Let's call it 9 or 10 people. Great, we found the sick people, but wait. We also have to test the 9,990 healthy people.
Yes, and your test has 95% specificity. That means it correctly identifies 95% of them as healthy, but it also means it gets it wrong 5% of the time. You have a 5% false positive rate.
Let me do the math. 5% of 9,990 healthy people. Wow, that's roughly 500 people.
So let's look at your final results. Your screening program has identified about 510 people who tested positive. But we know from the prevalence that only 10 of them actually have the disease.
So if a patient gets a positive result and asks me, "Doc, what are the chances I'm actually sick?" I have to look at them and say, well, out of the 510 positive tests we handed out today, only 10 are real. So your probability of actually having the disease, your positive predictive value, is less than 2%.
Exactly. And think about the human cost of that 2% PPV. Think about the panic you've just inflicted on 500 healthy families. Think about the invasive follow-up biopsies, the risk of surgical complications from investigating false positives, the profound anxiety, and the massive waste of healthcare resources.
It's a disaster. The textbook provides a brilliant real-world example of this mathematical trap using beta thalassemia screening in the UK. Researchers established a diagnostic cutoff using mean cell hemoglobin levels in 2 specific London hospitals that served a population with a very high prevalence of the disease. This cutoff worked beautifully. Because the prevalence was high, the PPV was about 77%. It was highly efficient.
But then, they assumed they could just scale it. They took that exact same test with the exact same numerical cutoff and applied it to different districts with a much lower prevalence of beta thalassemia. Because the prevalence dropped, the PPV plummeted. It fell to anywhere between 1.3% and 30%. It caused a massive, unmanageable workload of false positives for the local clinics. They had to completely redesign the screening pathway to include a second confirmatory test just to increase the overall specificity and make the program viable.
This is why health technology assessments and rigorous economic modeling are so critical. You have to know if scaling an intervention is actually going to be efficient or if it's going to bankrupt your system with false positives. Now, this kind of rigorous economic thinking was scaled up to the global stage in 1993 with a landmark report from the World Bank titled Investing in Health.
That 1993 report was a watershed moment in global public health. It fundamentally shifted the paradigm. Before 1993, macroeconomists and politicians often viewed global health as a charitable endeavor. The old logic was a country focuses on industrializing, it gets rich, and then as a byproduct of that wealth, it can afford to be charitable and build hospitals to treat its poor.
But the World Bank completely flipped the script. They looked at the data and argued that health isn't a byproduct of wealth. Health creates wealth.
Exactly. A healthy population is the foundation of economic productivity. If children aren't dying of malaria, they can attend school and become educated. If adults aren't debilitated by preventable chronic diseases, they can work and build businesses. Therefore, healthcare is not a black hole for charitable spending. It is a vital, high-yield macroeconomic investment.
But to convince finance ministers to invest, the World Bank needed a metric to prove the return on investment. This is where they popularized the use of Daly's disability-adjusted life years. Can you explain dailies for us? Because earlier we talked about QALIs and it's easy to get them confused.
It is a common confusion. Remember, a Creeley quality-adjusted life year is focused on maximizing the good. It measures the extra months or years of life of reasonable quality a person might gain as a result of a treatment. A daily, on the other hand, measures the burden of disease. It measures the loss of health. One daily equals 1 year of healthy life lost, either due to premature death or living with a disability.
So health economists use dailies to figure out where a disease is doing the most damage to a population, and then they calculate the cost per daily averted to prioritize which interventions offer the best value for money.
Yes, and using this metric, the 1993 World Bank report showed that low and middle-income countries could avert a massive portion of their national disease burden just by implementing what they called an essential package of care.
And this package wasn't robotic surgery or advanced oncology. It was a list of incredibly low-cost, highly effective public health interventions. Childhood immunizations, micronutrient supplementation, basic family planning, and maternal health care. The report demanded a total systems redesign for developing nations. It told them to stop pouring their limited budgets into expensive, discretionary, highly specialized hospital services in the capital cities, and instead build robust primary care networks across the entire country.
Which perfectly bridges us to the next vital phase of our analysis, the equity-oriented approach. We just spent a lot of time asking, are we doing things right and efficiently? But efficiency is blind to fairness. Now we must ask, are we reaching everyone?
When we look at the global architecture of inequality, the sheer scale of it is breathtaking. The textbook points out that high-income countries spend roughly 200 times more per capita on healthcare than low-income countries. That is a chasm. But what's even more fascinating for system designers is that even if we compare countries within the exact same income brackets, the political choices they make in system design yield wildly different health outcomes.
The classic comparison in the literature is Costa Rica versus the United States. The U.S. spends an astronomically higher amount per capita on healthcare than Costa Rica. It possesses some of the most advanced medical technology and research institutions on the planet. Yet Costa Rica consistently achieves a higher life expectancy, around 79 years, compared to the U.S. at roughly 78 years.
How is that possible? How does a country with a fraction of the budget beat an economic superpower in basic survival metrics?
Costa Rica achieved this through a relentless, decades-long political commitment to public primary care and universal geographic access. They built a system called eBayis, where multidisciplinary primary care teams, doctors, nurses, and crucially community health workers are assigned to specific geographic sectors. These teams physically walk house to house, mapping the health needs of every single citizen, ensuring preventative care reaches the poorest communities. It proves that equitable system design can absolutely outperform sheer, uncoordinated financial expenditure.
And when we talk about how uncoordinated markets failed to reach everyone, we have to talk about Julian Tudor Hart. He was a British general practitioner working in a deeply impoverished Welsh mining community. And in 1971, he published a paper in The Lancet where he coined a brilliant, deeply depressing rule called the inverse care law.
The inverse care law is one of the most enduring observations in public health. It states that the availability of good medical care tends to vary inversely with the need for it in the population served.
Let's translate that into reality. It means that in a purely unregulated, free market health system, healthcare resources, the most talented doctors, the newest clinics, the best MRI machines will naturally migrate away from the sickest areas and towards affluent areas. The resources go where the population is generally healthier but has the highest ability to pay. Meanwhile, impoverished, highly diseased urban centers or rural areas are completely starved of resources. The market actively punishes the sick.
So the challenge for public health is, how do we actively intervene against the natural gravitational pull of the inverse care law? Historically, a massive step forward in this fight was the 1978 Alma Ata Declaration, organized by the WHO and UNICEF.
Alma-Ata was a revolutionary moment. It launched the Health for All by the year 2000 strategy. And a major inspiration for this global declaration was actually the Chinese barefoot doctors model from the 1960s and 70s.
Yes. China realized they could never train enough elite physicians to cover their massive rural population. So they gave basic practical medical training to agricultural workers. These barefoot doctors remained in their own rural communities, providing preventative care, basic hygiene education, and first aid. It was a radical decentralization of medical power.
And building on that ethos, Alma-Ata championed the true meaning of primary health care. Now, as clinicians, we often lazily think of primary care simply as a general practitioner's office where you go for a sick note or a blood pressure check. But public health defines it much, much more robustly.
True primary healthcare must be universal and highly accessible without financial barriers. It must be fundamentally community-based, meaning it understands the local epidemiology. It must be the patient's absolute first point of contact with the health system. It must be comprehensive enough to handle the vast majority of common problems, and crucially, it must offer continuity of care over a patient's entire lifespan.
And in highly functional, equitable systems, primary care acts as a gatekeeper. Now, patients sometimes hate this word because it sounds restrictive, but structurally, it's brilliant. In a gatekeeper system, you don't just wake up, decide you have a headache, and book a direct appointment with a top-tier neurologist. Your primary care provider evaluates you first. They regulate and coordinate your access to specialists.
It prevents the chaotic doctor shopping that happens in unregulated systems, where patients undergo duplicate, expensive imaging and end up on dangerous cocktails of uncoordinated medications. Systems anchored by strong primary care gatekeeping consistently produce better population health outcomes and lower mortality rates than heavily specialized hospital-centric models.
Yeah, but even if you build a beautiful primary care network, we still have to confront the financial barriers. We have to talk about how people pay for care. Because out-of-pocket, or OOP, payments are devastating to equity. When systems rely heavily on patients reaching into their own wallets to pay cash at the point of service, it acts as a massive regressive tax that heavily penalizes the sick and the poor.
The clinical and economic literature tracks a terrifying phenomenon caused by this: catastrophic health expenditure. The World Health Organization defines this as the moment when a household's out-of-pocket health costs exceed 40% of their total income, after their basic subsistence needs, like minimal food and shelter, are met.
40% of your disposable income just to stay alive, that's essentially instant bankruptcy.
The human toll is profound. The textbook cites data showing that in Asia alone, accounting for out-of-pocket health expenditures push an estimated 78 million additional people into absolute extreme poverty. Illness doesn't just damage the biological body. In inequitable systems, the financial cost of treating illness actively generates poverty. It's a vicious cycle.
And before we get too smug in the developed world, it is vital to note that inequity isn't just a problem in developing nations without safety nets. Let's look at high-income countries that actually have robust, tax-funded universal health coverage, places where care is theoretically free at the point of use. Even in these systems, the data shows a persistent, stubborn, pro-rich inequity.
Yes, the data from universal systems is remarkably consistent. While primary care in these countries tends to be utilized quite equitably across all income brackets, when it comes to specialist care, there is a massive pro-rich bias. Higher income, university-educated groups utilize specialist services significantly more often than lower income groups, even when their clinical level of medical need is exactly the same.
Wait, if the specialist visit is free for both of them, why does the rich person get the hip replacement faster?
Because the wealthy are infinitely better equipped to navigate the labyrinth of the citadel. It goes back to empowerment and candidacy. The wealthy have the administrative time to sit on hold for an hour. They have the health literacy to articulate their symptoms perfectly and aggressively demand specific referrals from their GP. They have the reliable transportation to get to centralized specialist centers. And they have the social capital to advocate for themselves in complex, intimidating bureaucracies. Again, access is not just handing someone a free ticket. It is the empowerment to actually use the ticket.
That is a brilliant encapsulation. Access is empowerment. So let's tie all of this together. We come to part 5, outcomes. After all the philosophy, the moats, the locked doors, the screening math, and the economic policies, we have to return to our central question. Does healthcare actually improve population health? Did we beat McEwen's thesis?
We did. While McEwen was largely correct about the 19th and early 20th centuries, the landscape of medicine is vastly different. But to prove it, We have to be rigorous about how we measure success. One vital tool we use is sentinel indicators.
I love the concept of sentinel indicators. Think of them as massive red flags for a health system. If a health system is functioning with baseline competence, certain events should almost never happen. For example, maternal deaths during routine uncomplicated childbirth, or avoidable deaths from a ruptured acute appendicitis in an otherwise healthy young adult.
Exactly. A death from appendicitis isn't a failure of medical science. We know exactly how to treat it. It is a failure of access, timeliness, or surgical quality. By tracking these sentinel events, we can measure the true functional reach of a health system.
And when we look at the broader epidemiological data, we have undeniable, spectacular success stories that definitively prove clinical health care drastically alters population health. The most striking modern example is HIV.
The data on HIV is a triumph of the medical model. The textbook highlights a Danish study that looked at the median survival time for individuals post-diagnosis. In the mid-1990s, before the advent of modern antiretroviral treatments, your life expectancy after an HIV diagnosis was a bleak 7.6 years.
It was a death sentence. But then, fast forward just a few years to the early 2000s. Thanks to the widespread, systematic introduction of heartily active antiretroviral therapy, that life expectancy for newly diagnosed patients jumped to 32.5 years.
Healthcare took a uniformly fatal, terrifying acute disease and, almost overnight historically speaking, transformed it into a manageable chronic condition. That is a pure, unadulterated victory for medical intervention and access to pharmacology.
Another incredibly instructive example is coronary heart disease, or CHD. We saw mortality from CHD drop massively in places like the UK and Finland over a couple of decades.
But the CHD story is deeply nuanced, and it perfectly illustrates the necessary marriage between public health and clinical medicine. The data from Finland showed that about 50% of that massive drop in national CHD mortality was due to population-level preventative risk factor changes. This was public health in action, aggressive anti-smoking campaigns, taxation on tobacco, and public education improving population diets and lowering cholesterol.
So half the victory was prevention. What about the other half?
Roughly 20 to 40% of the mortality drop was directly attributable to specific individual clinical medical care. The widespread use of statins, improved pharmacological management of hypertension, and advanced surgical interventions like coronary artery bypasses and stents. It definitively proves that public health prevention and clinical health care are not an either proposition. They are a necessary, synergistic partnership.
But, as we established earlier with screening, measuring these specific medical outcomes can be incredibly complex. We can't just look at survival rates and declare victory. We have to dive into the statistical biases. Let's do a deep dive into breast cancer screening, because this is a classic exam topic and a crucial concept for understanding public health data.
When we evaluate population screening programs like national mammography rollouts, we have to be fiercely protective of our data interpretation. We are constantly fighting two massive statistical traps: lead time bias and length time bias.
Let's role play these to make them crystal clear. Lead time bias. This occurs when a screening test successfully detects a disease much earlier than it would have been found clinically. But, and this is the tragic part, that early detection and early treatment do not actually change the ultimate trajectory or time of death for the patient.
Walk us through a clinical scenario.
Okay. Imagine a patient. Based on her genetics and tumor biology, she is destined to die of a specific aggressive cancer at age 70. In scenario A, without any screening, she lives her life normally until she feels a lump at age 68. She gets diagnosed, fights for 2 years, and sadly dies at 70. Her survival time from diagnosis is 2 years.
Now, scenario B, she participates in a national screening program.
Right. She gets a mammogram at age 60. We find the tiny asymptomatic tumor. We celebrate the early detection. But unfortunately, our current clinical treatments are completely ineffective for this specific molecular type of tumor. Despite early surgery and chemo, the cancer progresses and the patient still dies at exactly age 70.
Now look at how the data records this. On paper, the screening program looks like a miraculous success. The survival time from diagnosis just jumped from 2 years in scenario A to 10 years in scenario B. A statistician could publish a paper claiming a 400% increase in survival time.
But in human reality, you did not extend her life by a single day. She still died at 70. You merely increased the amount of time she lived knowing she had a terminal illness. You gave her 10 years of anxiety instead of 2. That is the illusion of lead time bias. You didn't push the endpoint back, you just pulled the starting line forward.
Exactly. And length time bias is just as tricky, if not trickier. This bias relies on the biological fact that tumors grow at vastly different speeds. Some are highly aggressive, fast-growing bird tumors. They sprout, spread, and kill quickly. Others are indolent, slow-growing turtle tumors that might take decades to cause symptoms.
So how does screening interact with the birds and the turtles?
A screening program happens periodically. Say you invite women for a mammogram every 3 years. Because a slow-growing turtle tumor spends many, many years in the body in a preclinical asymptomatic phase, your 3-year screening net is statistically highly likely to catch it.
And what about the fast, aggressive bird tumors?
The highly aggressive tumors often sprout up, grow rapidly, and become symptomatic in the intervals between the 3-year screenings. The patient feels a lump a year after a clear mammogram and goes to the doctor.
So simply through the mechanics of timing, your screening program naturally selects for and overrepresents patients with less aggressive, slow-growing disease.
Precisely. So when you look at your cohort of screen-detected patients and say, wow, they're living so much longer than the patients who found their lumps clinically, it is not necessarily because your early medical treatment was brilliant. It is because your screening net selectively caught the turtle patients who were naturally biologically destined to live longer anyway.
Taking these biases into account requires immense statistical rigor. For instance, researchers analyzed the widely celebrated 21.3% reduction in breast cancer mortality in the UK during the 1990s. By incredibly carefully adjusting for lead time and length time biases, they estimated that only about 1/3 of that mortality reduction was actually due to the mammography screening program itself detecting tumors early.
And the other 2/3?
The remaining 2/3 of the saved lives were actually due to vastly improved clinical treatments, specifically the widespread introduction of the adjuvant hormone therapy drug, tamoxifen. The medicine did the heavy lifting, not just the early detection.
It's a perfect example of why we cannot accept basic survival statistics at face value in public health. Now, as we wrap up this massive conceptual journey, we must briefly acknowledge the incredibly difficult context of the developing world. They are currently facing what the literature calls the double burden of disease.
Right. We've been talking a lot about high-income systems, but health systems in developing nations are fighting a two-front war. They are still battling the infectious diseases, the malnutrition, and the maternal health crises that were outlined in the original Millennium Development Goals.
But simultaneously, due to rapid urbanization, westernized processed diets, and gradually increasing lifespans, they are now facing a massive rising tsunami of chronic, non-communicable diseases. Diabetes, hypertension, cardiovascular disease, and cancer. They have to build their citadel to fight both 19th century infectious killers and 21st century chronic killers at the exact same time, often with a fraction of the budget. It is a monumental, staggering task for health policymakers.
It is, and it makes understanding every concept we've discussed today, efficiency, equity, primary care gatekeeping, absolutely vital. Okay, we have covered a massive amount of ground today, from the utilitarian ethics of system design to the crushing reality of the inverse care law to the intricate math of positive predictive values. It is time to test your attention. We are going to do a conversational review with 6 rapid single best answer style questions based closely on the source material. I will read the question. I want you, the listener, to actively think of the answer before we discuss it. Ready? Question 1. What is the specific name of Julian Tudor Hart's concept that describes the tragic phenomenon where medical resources naturally migrate to affluent populations that need them the least, while abandoning the sickest areas? What do you think? Give it a second. All right, tell them why it's the inverse care law and not just bad luck.
It is the inverse care law. And it's not bad luck. It is a predictable feature of unregulated health markets. The resources follow the ability to pay, not the burden of disease. If you missed this, I highly recommend reviewing the section on equity-oriented approaches and the availability of services in Chapter 2.10.
Perfect. Question 2. You are evaluating a health system. You are comparing 2 groups. One is a wealthy urban population. The other is a marginalized rural population. Providing the exact same baseline per capita funding and identical services to both groups is an example of what specific type of equity. Think back to the Australian Indigenous example.
The answer is horizontal equity. Remember, horizontal equity is equal access for equal need. It treats everyone the same. But as we discussed, if the baseline needs are wildly different, horizontal equity is insufficient. You would need vertical equity, unequal treatment for unequal need to bridge the gap. Review the definition of equity in the text if you need to solidify that.
Question 3. A national health system decides to implement a brand new, highly advanced screening test for a specific disease. However, the disease has a very low prevalence in the general population. Even if the new test is brilliant and has 95% sensitivity and 95% specificity, what specific statistical value will inevitably remain very low, causing headaches for clinicians. Remember the village of 10,000 people.
The answer is the positive predictive value, or PPV. This is the mathematical trap of rare diseases in screening. A low prevalence guarantees a low PPV, meaning most of your positive results will be false alarms. Review Section 11.4 on the properties of screening tests.
Question 4. What is the specific name of the statistical bias that occurs when a screening program appears to vastly improve patient survival times on paper, but in clinical reality it merely diagnosed the disease earlier without actually delaying the patient's ultimate time of death? Think about pulling the starting line forward.
That is lead time bias. You didn't add years to their life. You just added years to their diagnosis and their anxiety. It's crucial to adjust for this when evaluating cancer screening. Review Section 11.4 under cancer screening biases.
Question 5. What is the specific public health term used to describe the devastating situation where a household's out-of-pocket health expenditures exceed 40% of their total income after their basic subsistence needs like food are met? It's a strong word.
The term is catastrophic health expenditure. This is a primary driver of medically induced poverty globally, pushing millions into destitution. You can review this under the Utilization of Services and Financial Barriers section.
Final question, question 6. The World Bank's landmark 1993 report, Investing in Health, fundamentally shifted global health thinking. It moved away from charitable models by framing healthcare interventions as economic investments. What specific metric did they utilize to justify this investment by calculating the burden of disease? Not the good years gained, but the healthy years lost.
The answer is DALYs, or disability-adjusted life years. By calculating the cost per daily averted, they proved that investing in an essential package of primary care was highly economically efficient.
Excellent. We survived the deep dive. Before we let you go, I want to step back from the heavy math and the policy frameworks and leave you with a final, slightly provocative thought to mull over.
We so often think of healthcare access as a purely logistical, engineering, or financial problem. We think the solution is always building a new clinic physically closer to town, training more specialists, or lowering the insurance copay. And those things are vital.
But if we go back to Dixon Wood's concept of candidacy, we have to remember that true access relies heavily on an individual's perceived right to ask for help. It relies on them feeling worthy of the care.
So the provocative question is this: how much of public health is actually about social empowerment? What if the most effective, most high-yield medical intervention we can offer isn't always a new biological drug or a faster MRI machine? What if the most effective intervention is teaching a historically marginalized community that their health is genuinely worth fighting for and that they absolutely unequivocally belong inside the walls of the Citadel?
That is something to truly think about the next time you see a quiet, hesitant patient sitting in your waiting room. Thank you for taking this massive conceptual deep dive with us today. Here are the details of this episode.
Access to healthcare and population health. Byline: when care is out of reach, sisters, barriers, and the architecture and access.